Our next talk, we're very, very excited to have Dr. Wendy Chung here with us. She's going to be giving some clinical updates about OCNDS. Please welcome Dr. Chung.
Great. For those of you who don't know me, I'm the Chung, I guess, in Okara-Chung syndrome. So within this, I'll give you a little bit of update. I'll be honest, you've heard straight from the families and the individuals. So this is going to be a bit quantitative, but really you've seen the real essence of what this is and the challenges it has. I'm telling this through the story of the Simon Searchlight, which is a structure that we have for collecting data, not just on OCNDS, but on many different conditions. And I'll actually give a little flavor and some commentary about sort of a compare contrast as we go forward with this. I'll just go very quickly through most of these, but it's powered by a very large group, some of whom are here today, and supporting, as I said, OCNDS as well as almost 200 other conditions. As we're doing it, we do it in partnership in terms of scientists who are using the data every single day. The idea is that participants can donate their data once and have it used by many, many others over time. I won't go through too much of this today, but in doing this, this is a living registry that continues to evolve so that we have longitudinal on data on people over time. And I'll just say personally, a lot of what I do as I think about this or the compare contrast, this particular gene, CSNK2A1, is something we call a kinase that you'll hear more about. There are other related genes as well. And I'll just say that one of the other genes that I personally work on that's kind of the opposite, a phosphatase, we actually are in clinical trials for small molecules or medications to work on that. And so there is hope, I guess, is one of the points that I want to make, that there is progress that's being made. And you have an amazing room full of scientists who are working for you behind the scenes to be able to continue making some of that happen. With this, I know it's a lot of information that we ask from you, but we do it because it's powering all of those researchers. We've tailored the instruments that we use to respond to the symptoms that you all are talking about and that you've heard today, mostly related to behavior, sleep included within that, and other things that are related, and understanding how that changes over the life course, because I do think it's different when you're 3 than when you're 13 than when you're 30. And as we do this, we are trying to also listen to you. So we have something that we call the voice of the community, continue to help us to iterate, tailor, and improve what we're doing over time. Just very briefly, for any of the families who aren't sure if they're in or are concerned about whether or not they're up to date with things, we've got some of the staff out in the lobby to be able to help you with that. And as we do this, we also have updates that come out to you all. For any of the researchers in the room, this is also the mechanism for you to connect to families. And we're happy to talk to you about it later, but I won't take precious time right now talking about that. As we do this, the Simons Foundation has also invested in, for some of you who have donated blood, to collect and to make mini brains, basically. Take those blood samples and make those into brain cells that the researchers can use in a dish to be able to test out some of their ideas, potentially in a preclinical way, so that we don't do tests and experiments on people. We do it on the samples from them in a dish to be able to do this. That's quite a resource that's been donated to do this. And for any of the researchers in the room, those are all freely available or available to you for the low cost of shipping, but a very small fee associated with that. As well, all of the data that I'm going to talk about is available. Just very briefly, these are some examples of what researchers have done with the data in any of these publications. We're happy for anyone who's interested to be able to see that. And as we do this, we encourage people to publish in an open access way so all the families can get access to that information as well. Okay, so now to the heart of what we're going to talk about. So there are many people, this is an international registry, and we've set this up so that we support many, many different languages around the world so that as many people can participate in this as possible. At this point, I'll tell you on data for about 100 people. We've had about 174 who have registered some interest. About 111 have gotten to the point of actually starting to provide data. And as I said, this is a living registry that continues to take data over over time. This is something that's more for the research community than for the parents, but parents, you're welcome to be able to look at this as well. This is a plot of the mutations or the different genetic variations that we see within the gene. I call it a lollipop plot. So each one of these dots is representing an individual participant. But what you may or may not be able to tell from this is that there is one position at amino acid 198 that, as you can see in parentheses, actually has 27 participants of these 130 that are represented in this plot. Those are individuals are unrelated. So it's not as if there's one big family with 27 people. These are individual unrelated people. And that's actually telling us something about what's going on with the gene as we do it. In addition to each one of the lollipops that I'm showing you here that has a single amino acid or single building block that's changed in the protein, there are also several individuals who have deletions of the gene, either a portion or the entire gene, or others where we think it causes one of the two copies of the gene not to show up for work that day. And so as a result, there's half of the amount of that protein that's made. I won't have time to go into it, although others will. There are some differences between the different mutations that we see. They're subtle, and they all tend to produce something. But if those of you want to start comparing notes across the room, you may, in fact, yourselves realize that there's some differences within the community for different individuals. Just to show you, these are representing individuals from around the world, as well as around the United States. And as I said, these are the samples that are available to any of the researchers in the community. And I should just say, all of these slides will be available afterwards. So if there's anything anyone wants, feel free to, don't worry about taking notes. We'll give you everything. These are the iPSCs, or the induced pluripotential stem cells, that are available, again, for the researchers. And this continues to be a resource that's continuing to grow and evolve with additional mutations, both that the foundation's making as well as the Simons Foundation has made. Okay, let me get into the heart of what you really care about. So this is a distribution showing you what we know, and I'll also point out the limitations of this. So this is showing you the age distribution of the individuals I'm going to tell you about, 96 individuals who all have either pathogenic or likely pathogenic variants. That is, individuals I'm quite sure have this diagnosis. The important point that you'll note is that most individuals are before the age of 15. We do have a few adolescent young adults. What you don't see on this graph, though, is you don't see individuals who are middle age or older. It's not that I don't think they're out there, but they haven't necessarily accessed the genetic testing so that they know they're a member of this club and so that they can join something like Simon's Searchlight. For anyone who's interested, I actually do think that we need to have, I'll call it a campaign, to be able to understand individuals over the life course and to be able to access and get testing to those individuals, because there are other conditions that I've studied where, when I've done that, I've realized that this is not just a developmental condition, but there are other challenges that come on later in life that are important to know, because when we know it, we've been able to anticipate those and use medications to prevent some of those things. So if there were a part of the research agenda in going forward, this would be a part of my wish list in terms of doing this. As we see this, we see an equal number of males and females, not surprisingly, based on what we know about the genetics. The good news that I'll tell you, for those of you who have heard me talk about this before, is they're not surprises. So if anyone was worried about, is there another shoe that Wendy's going to talk about that's going to drop? There isn't. I'll reassure you of that. As far as we know, and as far as you've heard from the videos and the testimonials, this is largely something that's above what I call above the shoulders. Mostly, in other words, it's a brain condition. It's a brain condition where sometimes the brain cells innervate or control other parts of the body, but largely it's a brain condition as we think about this. And as I said, what we've seen so far is largely about the brain and behavior and the brain function. When it comes to those, we see all different manifestations. So everyone still has the same dimension of this genetic diagnosis, but in terms of the behaviors that we see manifest, they may be different, and you may add on diagnoses as the individual gets older. So as individuals are getting older, especially as they're going through adolescence, especially as there's some hormonal changes and other changes, there may be things that evolve and new things that either become obvious or, in fact, behaviors that are evolving over time. We see this very, very early on, as you've heard already, for parents, even some parents who can sort of go back in the retroscope. I've had parents tell me they just knew the first time they held their baby, especially for moms who've had other children, that they just felt different. They felt that there was something different with their child, and even been able to go back and think prenatally, some cases, how things like growth were different in utero. In seeing the medical aspects, and again, all of this will be available to you afterwards. We do see other factors, though. Some of those other factors, gastrointestinal issues, as you've heard about, are quite common. I do think a lot of that has to do with motility issues in terms of the brain telling the gut, moving things along, the muscle tone, the contraction that goes with that. And so we see problems of constipation, diarrhea, gastroesophageal reflux. We see these commonly across very similar conditions, so it's a very consistent theme that we see. We do see problems with growth, and when I say endocrine issues here, largely those are issues with growth. You could see it in terms of some of the videos, from some of your own children. They tend to be skinny. I think of them as string beans in many cases, a little bit on the shorter side. Not to say absolutely everyone is, but that is something that oftentimes is the first thing that's observed right away. Some of the other things we see in terms of the senses, the eyes, again, when I think about it, it's neurologically another extension. Sometimes what's coming in terms of innervation or brain cells, because again, the eye being able to see is in part a nerve coming out of the brain. And so we see several issues related to that. Important to know because that's how individuals are getting input. And you've heard a lot about the anxiety. The anxiety leads to its own problems. If you can't predict what's coming at you next, it's completely obvious that you're going to be nervous about that. And so if if the vision is impaired in some way so that you literally can't see what's coming at you next, that leads to some of the problems in terms of anxiety and being able to anticipate things. So vision is one of the things we try and detect early and try and take care of. In addition to that, thankfully, the majority of individuals do not have seizures, but we do see seizures as a component to this. I'll go a little bit more deeply. And then over time, we also see some orthopedic issues in part due to the hypotonia, the low muscle tone. And then as individuals are going through their growth spurt, they may have some scoliosis or curvature of the spine that is part and parcel of that low muscle tone as well as the other issues. We do see some other orthopedic issues, some joint issues as well that can come with that. But largely, what I want you to take away from this is we're not seeing a huge burden otherwise medically of other things. So let me tell you what I'm not seeing. And I look for this very carefully across these conditions. I'm not seeing cancer, for instance. So again, with the limitation that I don't have individuals who are largely in their 50s, I'm not seeing cancer, at least as an early warning sign. I'm not seeing largely other structural things with the way the body formed. I'm not seeing birth defects like congenital heart disease or other problems. So, for most of those other things, I think by the time if your child is 10 or older, you've seen the medical manifestations. I'm not expecting the other shoe to drop, with the exception that developmental, behavioral specific things may change over time. So some of these other things that we see, and you've seen them from you know them from some of your children, problems with coordination, movement disorders, or problems in terms of the gross motor movements as well, some of the coordination issues that you see in the light blue. Sometimes your pediatrician, again, as part of growth issues, may have seen a smaller head circumference as well as being a little bit shorter or a little bit skinnier as well. This is what I alluded to in terms of seizures or epilepsy. It's about a quarter of individuals who have had a seizure at some point in their life. It's many different types of seizures. So it's not everyone who's had the tonic, clonic, convulsive types of seizures. There are some people that just have this kind of dazed petit mal, but they have absent seizures where they look just a little bit out of it. So we see various different seizure types. And my advice is always that if you're concerned, to bring this attention of your neurologist, if you have a neurologist, your pediatrician, and if you happen to have the ability to take a video of it, take that so that your doctor can see what it is that you're seeing at the same time. When we look at these, some people ask me, well, my child is so and so years old. I haven't seen a seizure yet. Does that mean we're in the clear? Is everything okay? For most of the part, the seizures are occurring before kids are going to kindergarten or before the age of 5. And so for the most part, if your child is over 5 and hasn't had a seizure, it's likely, I think, that at least based on what we know today, that we're not going to see seizures in the future, with the limitation of what I said with the age distribution of what day data we know about today. And so we're still waiting to see more and more people going through puberty, more and more people going to other parts of through the life course. I'll show you medications in a second, at least what people have reported to us in terms of doing this. Many people continue to need to be on medication for seizures to prevent future seizures, but in general, this is not one of the severe epilepsy disorders where seizures overtake someone's life. This is much more, as you've gotten the flavor of it, a behavioral issue and problems in terms of communication, anxiety, and frustration in those ways. I won't go into lots of detail, but as you can see, if you and take be sure and take this to your ophthalmologist if you like, but we see many different visual problems. And this is something that it's tricky in terms of getting a good eye exam. Your kids aren't going to read the eye chart to the doctor in terms of being able to see what they see. So a pediatric ophthalmologist who treats children with disabilities is oftentimes the best to be able to get some sense of if there is any visual impairment. As I said, short stature or problems gaining weight is something we see sometimes. And then the orthopedic issues, as I talked about, is mainly scoliosis, but largely not a big issue. We're not seeing lots of problems in terms of hip dysplasia, knee problems, other things later on. For the heart, again, the good thing is these numbers are very, very small numbers, and I would say are very similar to what we see in the background, not a major issue. That's what I want to reassure you about. And then, as I said, the gastrointestinal issues, a lot of issues in terms of diarrhea, constipation. There are issues that come with having a restricted diet, which is more related to behavior, and with that may either take care of the constipation or make the constipation worse, depending on whether or not you get that right mix in terms of having things flow through the system. With this, the surgeries that we've seen people need have been largely in young childhood. We haven't been seeing people coming over and over for various surgeries. So things like tonsillectomies, adenoidectomies, tongue ties, cleft lip and cleft palate is something that we have seen that's been a bigger surgery when it's been needed. Sometimes testes that are not descended that need to be tacked down. But for the most part, these have not been major, major sort of surgeries like open heart surgery or other things. Medication use is, for me, an indicator of how serious the problem is and how chronic the problem is. And that's why parents and families treat them with medication. And so that's what I mean in terms of seeing this. GI issues are serious enough that people need to try medication, and oftentimes the medication does help. Seizures, obviously, and then it becomes a bit of what I call polypharmacy for behavior. And you were hearing a little bit about this from Jennifer Sills, needing to use oftentimes multiple medications, some for sleep, some for anxiety, some for mood disorders, some for being able to even things out. And the bottom line is there's no one formula or combination of medications that seems to work best. Unfortunately, it's a bit of trial and error. And I will say going to your doctor and trying to get one of those genetic tests to tell you what medication is going to work, don't bet the farm on that one. Not likely to help very much, if at all, in terms of helping. In terms of seizure medications, again, this is what families told us for the 48 families that did use medications, in terms of medications that seemed to be able to keep seizures under control. We largely were not seeing the need for multiple seizure medications, so that was good news to me. Very briefly, in terms of the developmental assessments and how individuals are doing over time, this is one of the, these are your data. So what I mean by this is the Vineland Adaptive Behavioral Scale is a caregiver reporting back on what they see their child being able to do. So this is your observations and presenting back your data to us. This is not that your child has come to see us in clinic and we've done a bunch of fancy testing. This is what your observations are. And I'm going to break these down into the different domains that we see. In each one of these cases, each dot is a person, so a person with OCNDS, and I'm showing you their age on the x-axis. So this is not one person over time. This is what we call cross-sectional data with each dot as a different person, but I'm showing you this as if the children sort of as a community, they're growing up. So to try and give you a sense of what's happening to individuals over time, and I'm showing you that yellow line to be an average of what the group is doing over time. So higher scores are better, and I've converted these into on the y-axis, what is essentially a level of functioning in years. So is my child acting like a 2-year-old, a 3-year-old, a 4-year-old, however that is. So for this first one, this is expressive language. And this is all the different mutations together. And for the researchers, I'll just put it out here. with each of these dots as being different, you don't see that there's a tight clustering of these. It's not as if everyone is being right on that line and everyone is behaving in the same way. And the way I look at the data is there's actually variation, and there's a fair amount of variation. And that may be in part related to, and this is actually the $1 million question, what? What is accounting for that variation? And is there something we can learn in terms of those individuals who have managed to break open some potential in the children? To a certain extent, it's related on the actual mutation. And if we want to in Q&A, we can start going into this. But that is part of the answer, is the different genetic variation in the CSNK2A1 gene as part of the answer. The other part, though, are other things that this is what this is meeting is about, is to learn from each other, what I call tips and tricks or life hacks. What have you learned that's been effective? What have you learned that hasn't worked, so that we don't all do that the same thing? But how do we figure out those things that have worked? And I do my own personal sense watching my own patients is that the younger children growing up have learned many of the tips and tricks from the older generation, in addition to having new technology to be able to unlock some of the potential that I think has been sitting there dormant in some of the older children, but we didn't have the technology or some of the training methods of being able to open up those opportunities. And so as we're doing it, that's going to be my main thing in terms of for families. A near-term win for us collectively is going to be able, I think, to access some of those inner skills, inner abilities that individuals have, even if they're not verbal and can't express it and speak it, but they still have that ability. And part of the reason I say that is because I personally have been doing more tasks that are based on receptive rather than expressive language. And I can tell that individuals are understanding me based on the task we can get them do that are dependent on understanding and performing things. They can't utter it, they can't talk to me in terms of telling me the words, but they can show me that they're understanding what's going on. And so even though expressive language is increasing, the slope of that increase is what is a concern to many people. And I understand that as well. Another, and I actually, again, take this as one of the best, most hopeful slides that we have, is around personal care skills. So these are the everything days you want to do to be independent. So whether it's cooking, whether it's self-care, whether it's bathing, brushing teeth, doing tasks around the home or in a job potentially outside the home. And the point that I raise in this is the slope for this is actually the most positive of the slopes that we have in terms of domains. So people are able to learn. People are able to learn tasks that are important and that help get through the day in terms of doing things. Hopefully learn things that bring joy and bring satisfaction in terms of doing this. And if you look at this, many individuals actually able to learn quite a few things. So again, if you look at some of the older individuals and some of them who have been able to learn to do quite a few things, that's important. And I do think there is potential. When it comes to social development, though, this is one that's been harder. And you can understand it in terms of if individuals are having trouble with anxiety, being in new situations, being able to meet new people, being able to make connections. From a social point of view, I think that's why we're seeing the limitations and why the scores and why the improvement over time or improvement as people get older is not quite so good. This is a hard thing in terms of meeting new people, and it's easier in terms of what you know and being in your comfort zone to be able to do it. Um, this is now for gross motor movement. This is things like running, skipping, hopping, jumping, all of the things that your big muscles do in terms of being able to do things. Individuals can learn those skills over time. Obviously, learning to run, walk, even things like swim, other gross motor skills. And the reason this is important is this enables them to do many of those personal care skills or many of those daily activity skills. And so if they're able to be coordinated enough to be able to do those, then they can achieve more as they're going through. This is a standardized instrument, the child behavior checklist. I'm going to break it down into two ages. We do the little ones at age less than 5 for this. And hopefully this is something that resonates and that we've got this right. Again, this is you reporting to us what you've been observing. Anxiety in terms of new things. So novelty is not our friend. The other things in terms of just impatient, partially it's difficulty with attention and focusing, but a lot of it is impatient. And as you you heard, just needing a lot of direct supervision, a lot of just a lot of one-on-one. As the individuals get older, there are these issues with distractibility, ADHD in sort of an extreme, but also things that, again, demanding attention and oftentimes the obsessions, I think, are in part also a comfort zone, coming again to certain things because that's what feels natural, that's what feels comfortable, and that's because that's what's less anxiety provoking. So, to sum it up, the good news for me is that I'm not seeing people fall off a cliff. I'm not seeing people regress significantly. I'm looking for it all the time, but I'm not looking for excuse me, people that are developing Alzheimer's, Parkinson's, neurodegenerative conditions otherwise, with the limitation that we don't see in older community yet. We do, though, have severe cognitive behavioral impairments. But I will say, with the hope that there are ways of being able to get individuals to be able to do more with less, if we can support them with some of the other technologies, not just medications or genetic therapies as we go forward. I'm not excluding those, and I do think ultimately I hope we get to something like that. But in a short term, I think we have short term wins if we think together. And we don't have to do it alone as a community in this room. We can actually do it broadly as a community of individuals who have challenges from a neurodevelopmental point of view. And that's part of what I think is hopeful. So with this, I'll just sum up by saying that, again, as we're doing this, Simon Searchlight, we're celebrating 15 years of being at this, and we're still going strong and still trying to continue to do things across the community that'll help support us. And as we go forward, I'm glad to, you guys tell me, am I glad to take questions now or later?